On Fire, Anti-NMDA Receptor Encephalitis by Tina Payne. In 2009, Susanna Cahalan was a healthy 23-year-old reporter for the New York Post when she began to experience numbness, paranoia, sensitivity to light, and erratic behavior. She didn't know what was happening. Then her symptoms suddenly got worse. She began to experience seizures, hallucinations, increasingly psychotic behavior, and even catatonia. Her symptoms frightened her family members and baffled a series of doctors who all thought Susanna was suffering from mental illness. She had been hospitalized for a month, spent $1 million on tests and blood work, and still there were no answers. Until one doctor asked Susanna to draw a clock on a piece of paper. Susanna drew all the numbers on the right side of the clock and left the left side of the clock blank, indicating to her doctor that she had a left side spatial neglect, also indicating that she had a neurological problem. Her neurologist, Dr. Najjar, told her family that the right side of Susanna's brain was likely inflamed. Her brain was on fire. Susanna Cahalan was diagnosed with anti-NMDA receptor encephalitis, which is a neuroautoimmune disorder that was newly discovered in 2007. Anti-NMDA receptor encephalitis is a disorder in which antibodies attack the NR1 and NR2 subunits in the brain. These are the receptors that are responsible for controlling the electrical impulses in the brain that control our judgment, perception of reality, human interaction, and autonomic functions like breathing and swallowing. Anti-NMD receptor encephalitis is not contagious, and it is not considered to be hereditary. It is more prevalent in women than in men, and it occurs most often in young adults and children. It is usually associated with a tumor, such as lung cancer, thyroid, breast and colon cancer, neuroblastomas, and teratoma tumors. Teratoma tumors of the ovary is the most common type of tumor found in women. In men, the tumor is often found in the testes. The role of a tumor in anti-NMDA receptor encephalitis is not fully known, but what is known is that most tumors associated with this disease contain neural tissue with cells identical to that found in the brain. The theory behind this disease process is that antibodies are initially formed against the NMDA receptors found within the tumors and then go on to attack similar-looking receptors in the brain, thus causing the symptoms associated with anti-NMDA. The most common presenting symptoms in teenagers and adults include anxiety, insomnia, delusions, mania, and paranoia. In young children, behavioral changes, temper tantrums, hyperactivity, and irritability are seen. A reduction in spontaneous speech occurs in all groups, and almost all patients will develop abnormal movements such as orolingual facial dyskinesias, tongue rolling, and dystonia and rigidity of the trunk and extremities. Seizures are common in 50 to 70% of patients, and the most frequent autonomic presentations include fever, tachycardia, hypertension, bradycardia, and hypersalivation. A diagnosis of anti-NMDA receptor encephalitis requires detection of antibodies in either blood or cerebral spinal fluid. Tests on the cerebral spinal fluid are the most accurate. EEGs are used to assess and evaluate for seizures. Methylprednisolone IV steroids are given at high doses along with IVIG after tumor removal as a first-line therapy. The next line of treatment includes plasmapheresis, and if a patient's diagnosis and treatment are delayed, the use of more powerful drugs such as Rituxan and Cytoxan may be required to eliminate the anti-NMDA antibodies from the body. Lastly, inpatient rehabilitation programs with intensive physical, occupational, and speech therapy are also needed to help patients regain function. Anti-NMDA receptor encephalitis is a serious life-threatening disease. The recovery process is slow. It can take months or years. But with early diagnosis and treatment, 75% of patients will have substantial recovery back to their baseline. The rate and degree of recovery are directly related to how quickly a diagnosis is made and treatment is started. Sadly, not all patients will recover from anti-NMD receptor encephalitis. For these patients, cardiac arrest is the most common cause of death. In the case of Susanna Cahalan, there was no teratoma tumor present. Doctors do not yet fully understand why certain people without teratoma tumors get this disease or how the disease is triggered when no tumor of any kind is present in the body. Doctors are also not certain how the antibody gets through the blood-brain barrier or if it is synthesized in the brain. Until the ongoing research on anti-NMDA receptor encephalitis yields more information, the current focus must be on early detection and treatment. And this concludes my presentation, and here are my references. Thank you.